I started doing things for the Infectious Disease Society probably about 10 years ago, and I had some interest in it, but I had a friend who's actually a medical school classmate who does ID, who talked me into joining a thing called the Clinical Affairs Committee, and he was the chair of that. I ended up being the chair of that. Before I got to where I am now, I used to do basic research. And so we did some health outcomes research as part of that committee and published a couple of papers about that. I'm still involved in doing some of those things for IDSA, mainly aimed at trying to make sure that infectious disease physicians get recognized for the value they bring to the healthcare system, not just with pats on the back, but with support for what it's worth. So after I was done with that, I was asked to go on to the committee, and then I got a phone call from Jim Hughes, who's the chair this year, and asked me if I would do it, and I said, yeah, definitely. It's interesting because I started on this committee the same year that ID Week started. It used to be the IDSA annual meeting, and as part of that, the two organizations, well, three that were involved, IDSA, HIVMA, and Pediatric ID Society, and SHEA was totally separate. And so that was the first year that we brought SHEA in to make a combined meeting. There's a lot of cross between members that are members of both. They're much more focused on antimicrobial stewardship and infection prevention as what their main interest is, but there are almost 10,000 IDSA members, probably at least half of which are, or maybe even a little more, in direct clinical practice and do all that stuff. And so it's really gone to be a much more all-encompassing meeting. It's far and away the most relevant and important meeting for infectious disease as a whole, especially clinical infectious disease. So most of the sessions that I moderate, aside from some that are I'm just picking up things, have to do with what I'm got the most expertise in. I don't claim to be a telehealth expert, but it's one of the things that has come out of the Clinical Affairs Committee, and in part because, as you said, it's a really burgeoning area for medicine, and even though there are probably not enough infectious disease doctors, it's really a problem in areas where you have wide open spaces, like in the West, where you may have one large hospital and then it's 200 miles before you could get anywhere near someone, and it's a way of bringing the infectious disease doctor into that doctor's office or hospital or whatever to see the patient contemporaneously. The technology is so much better than it used to be that you can actually do that now. And it's not, faxing stuff here and getting it back. You can actually interact with the patient and have high definition cameras that, take a picture of the rash and things like that. So I think it's something that our discipline can really take advantage of. One of the talks this afternoon is being given by a person named Dr. Javed Siddiqui, who runs it's basically an infectious disease practice in California, and they cover some of the surrounding states, and they do entirely telemedicine. So they do patient encounters, they do infection prevention and antimicrobial stewardship via telemedicine as well. And as he put it he had to meet the presser this morning, he's not sitting in the car for 2 hours a day going to different places, and he can actually do work and have it be productive work as opposed to sitting and looking at someone's taillights in between hospitals.